Hi, I'm Frank Spear. I want to welcome you to this section. What we're going to talk about in this section is, I think, something that has had a lot of, I won't say controversy, but certainly a lot of conversation in aesthetic dentistry in the last few years, and that is anterior tooth preparation for porcelain veneers. A lot of people wondering, do you need to prep teeth? When do you prep teeth? When don't you prep teeth, etc. So what I'd like to do in this section is walk through how I think about the process of veneer preparation, or if you will, lack of veneer preparation, and then just show you a couple examples to illustrate some of the concepts. When we really think about it, if you look at conceptually what your options are for a traditional veneer preparation, kind of whatever that is, certainly you have the option of no prep. And the option of no prep is really dependent on the ability of how thin the ceramic can be made and what contour you're willing to accept. Obviously, if you take a tooth and you don't prepare it at all, and you add to it, the tooth is now bigger. It's more prominent, and it's typically also a little bit longer potentially. The question is that shape that you achieve after the addition what you want? If the shape you achieve after the addition is in fact what you want, and the color and thickness of material can be managed, then certainly you can do no prep veneers. There's no question. There are some very beautifully done no prep veneer cases around. Typically, what we need to do for most cases is, unless we're significantly adding some facial prominence or length, we typically are going to do some preparation. Now, there's certain advantages to even minimal preparation from the technician's point of view and the day of seating. From the technician's point of view, there's a definite finish line with reduction, as opposed to having to basically feather the ceramic out to almost nothing. From the point of view of the dentist seating the restoration, it's definitely easier to seat a restoration that has finish lines to tell you where to seat it, instead of something that has the potential to move around. And then typically, if you really want to know what most of my veneers look like, they don't look like either of these examples. My typical veneer preparation looks something more like this. It has a preparation depth on the facial that's determined by the color I'm trying to achieve more than almost anything. So once I know the final form of the tooth, and I know the color we're after and the color we're starting with of the natural tooth, that determines how much thickness of ceramic I need. That means I'm going to have to take off that much to be able to get the correct final form and color. And then generally speaking, I do reduce the incisal edge so that the technician has about 2 millimeters of incisal edge porcelain to work with, which means we need to know where the new incisal edge should be, so we take 2 millimeters from that depth to give the technician space. Now, in terms of a more traditional design, which the incisal butt margin really is, the other one that people talk about a lot is, well, should you wrap the incisal edge? In other words, your preparation actually goes down the lingual. And in clinical studies, it turns out there's no difference whatsoever between an incisal butt margin and an incisal wrap. There are some laboratory studies that show that the incisal butt margin is actually less fragile, that in fact the weaker prep design is the one that wraps the lingual. In practice, typically what determines whether you go down the lingual or not is how thick is the tooth. There's a lot of teeth that simply aren't thick enough to wrap up the lingual surface. If the tooth is thick enough to wrap the lingual surface, what's the advantage of that little wrap? It makes seating absolutely simple, because the veneer only goes to one place and it can't slip out facially on you. The challenge of not having the wrap up the lingual is, as you seat the veneer, it can move on you. It can move in a facial direction. So bottom line, those are kind of the 4 methods that you have of looking at what do you do about an anterior porcelain veneer. No preparation at all, minimal prep where you don't even go over the incisal edge, but you do put basically a chamfer finish line and some facial reduction on it. A typical veneer with the facial reduction dependent on thickness needed for color and some incisal reduction to give you a couple millimeters of porcelain, or go ahead and wrap it. And I think it's important to realize from the technician's point of view that the thickness of ceramic is what determines what they can do color-wise. So we know what the thickness of the enamel on the natural tooth is, around 3 to 4/10 of a millimeter in the cervical third, 5 to 7/10 kind of towards the middle, and then 7 to 9/10 or a millimeter up near that facial incisal area. But you have to keep in mind when you're doing veneers, often we're doing them for cosmetic reasons. The patient wants whiter teeth, they want prettier teeth, they want bigger teeth. So let's say their teeth are like a shade A3, but they want a bleach shade. So they might want to lighten at least 3 or 4 shades. Well, you typically look at it, that's going to require a ceramic thickness of 7 to 9/10 of a millimeter. You start looking at your options, and if you need 7 to 9/10 of a millimeter ceramic, maybe you add a few tenths of a millimeter to the facial contour of the tooth, but it still means you're going to have to take away at least 4 or 5/10 of a millimeter to get the thickness the technician needs. If you just add the whole 7 to 9/10, you typically get a very over-contoured tooth. Now, I actually don't have any no-prep cases to show you because I've never done a no-prep case. I'm a fairly firm believer in creating finish lines and creating a positive seat for the restoration. One of our visiting faculty here in Scottsdale, Sheldon Sullivan, has a beautiful no-prep case that he did with an orthodontist on the orthodontist's daughter. And it's a really perfect illustration of how to do no prep because the orthodontist set the teeth up. The teeth are very small teeth, and the orthodontist really set the teeth in position where everything you'd want is additive. So if you really look at the teeth, there's diastemas that have been left. Everything's been set up to come in and add to what's there. Now, if I was doing the case, honestly, I would have put a finish line around the facial and in through the interproximal to make a more positive seat. But Sheldon actually did it with no finish lines whatsoever, which meant the technician had to be very skilled at feathering all of that porcelain in to basically nothing. So that ceramic has to disappear to virtually no thickness whatsoever. And really, Sheldon and the technician did a beautiful job on the restoration of this case. It was set up beautifully by the orthodontist. But when you talk to Sheldon about the case, he'll tell you one of the hardest things he's ever done was to seat this case because the veneers wanted to move everywhere. They don't have that positive stop that you get when you have a cervical finish line, an interproximal finish line, and an incisal finish line. So it can be done. Obviously, it can be done. But it has to be a very special case that we do it on. Now, more commonly, we're going to prep teeth. And obviously, that means we're going to be doing some reduction of teeth. And so this would not be an uncommon looking set of veneer preps for me. Still almost 100% of the tooth in enamel, but there's definite stops. There's an incisal finish line, there's interproximal finish lines, there's cervical finish lines. What determines really how we reduce a tooth for a veneer? The condition of the tooth, obviously. Does it have big class 3 composites? Does it have a class 4 composite? Does it have a class 5 composite? We have to take into account caries and old restorations because those are definitely going to alter what the prep looks like. So in many cases, the restoration doesn't really end up looking like, quote, a veneer. It might end up almost looking like a reverse 3/4 crown. And maybe we say, well, it's not a veneer anymore, it's a partial coverage anterior bonded restoration. But the truth is, the way I think of things is there's full crowns, and anything that's not a full crown I tend to think of more as a veneer, or if you will, a partial coverage anterior bonded restoration. What other things affect how much we reduce the tooth? Tooth position. If the tooth's too far to the lingual, you'd think to yourself, well, I don't have to reduce the facial much. But you might have to reduce the incisal a lot. Because when we have a tooth too far to the lingual, if we want to move it out facially with restorative dentistry, we get a really thick incisal edge unless we reduce the incisal edge. If we have a tooth out to the facial, we're going to have to take a lot off to get it tucked back in. Tooth color, I already mentioned to you. If you want to change shade, 3-4 shades on a Vita shade guide, you're going to need 7 to 9/10 of a millimeter of porcelain. If you can't add 7 to 9/10 of a millimeter to the contour of the tooth, you're going to have to take some away from the tooth to make that work. And then finally, and an obvious one, when you're doing veneers, you're doing them electively. So the patient has to factor in here. And what the patient wants in terms of final tooth color, final tooth alignment, final tooth shape will impact what you have to do to the teeth themselves. Now, there's lots of variations on veneer preparation. And so that what it's telling you is there's a lot of different ways to do this that work. I'm going to show you two cases just simply to show you the steps that I follow and how I think about it. And the first case is actually just going to be a single central incisor. And then the second case will be my daughter Julie, which ends up being 10 maxillary veneers. And we'll just look at the thought process for that. Before we look at either case, let's just talk about burrs. My burrs that I've used since around 1990 are burrs that John Coys and I designed. We were partners from 1985 to 1995. And somewhere around 88, 89, 90, we designed these burrs with Brasseler. And the important thing about them is to know the diameter of them, because that's how we control depth. And the three burrs that you really need to know the diameter of is the KS0 on the far left. It's 1 millimeter in diameter. A KS1, 1.2 millimeters in diameter, and a KS2 is 1.4 millimeters in diameter. And then in addition to these burrs, for veneers, traditionally I've used depth cutting burrs from Brasseler. 3/10 of a millimeter depth cutters, 5/10 of a millimeter depth cutters, 7/10 of a millimeter depth cutters. I have to tell you today for veneers, what I tend to use is a system that Bob Winter, who is a partner in our lab business with the Winter Laboratory, master ceramist and prosthodontist. Bob worked with Brasseler to develop these burrs that are under the RW name. And they're pretty much what I use today for veneer preparation. And the reason I like them so much is because of these 5 burrs. These 5 burrs are depth cutting burrs. And they make depth cutting for veneers very, very simple. So on the far left is a 2 millimeter tall incisal reduction depth cutter. Next to it's a 2.5 millimeter tall incisal reduction depth cutter. So when you start to do your veneer prep, if you want 2 millimeters of space, you simply run that 2 millimeter burr right through the incisal edge, and it makes perfect 2 millimeter depth cuts for you. In the middle, it says RW manned. That's a very conservative depth cutter for when we don't need a lot of thickness to our veneers, when we're trying to do minimal prep veneers. It will produce 3/10 of a millimeter cervical depth cut, 5/10 middle of the tooth, 7/10 up near the incisal edge. It pretty much assures you you're going to be left with enamel on the majority of the surface. When we want to change color a little bit more, we'll go to the one next to that, which is 5/10 of a millimeter cervical, 7/10 of a millimeter in the middle of the tooth, 9/10 up near the incisal edge. And when we really need to significantly alter the color of the tooth, we'll go to the one on the far right, which is 8/10 cervically, 1 millimeter in the center, and 1.2 incisally. And honestly, if you have a tooth that's so dark you need to use that, you may end up thinking maybe it's a tooth you should do full crown on and use a material that has a coping inside of it to cover that dark prep, rather than using a monolithic translucent type material. So those are the burrs we typically work with. And as I said, I'm going to show you 2 cases. The first one is very, very simple. It's a single central incisor. And the reason I'm showing it to you is simply to talk about the things that people ask when we talk about veneer preps. Do you break contact or not? Do you go subgingival or not? Do you go over the incisal edge or not? And so let's just talk about it on a single tooth. Now in this particular patient, we have some things we have to correct first. We have some gingival level problems. The good news is it's actually very simply corrected in her with a gingivectomy, because she has a lot of excess sulcus depth on that right side. And so the first thing I did for her was to clean up the gingiva with a gingivectomy, then bevel it to thin it out with a little gingivoplasty. And now we're going to prep the right central incisor. So as I approach the right central incisor, I'm just going to walk you through the steps that I look at when I am prepping a set of veneers. So if I'm doing 10 veneers, I'm doing these exact steps, but I'm just doing it on more teeth. But the process is the same. So the first thing for me is to identify the old restorations that are there and the ones I think I need to remove or replace, like class 3 composites or class 4 composites, for example. In this case, she actually has a composite veneer that's bonded on, and it has a TMS pin in the tooth that's helping hold this composite on. So we're going to have to remove all of that. The next thing I'm going to do is identify my desired incisal edge, because my depth cut needs to come from my desired incisal edge position. I want to reduce 2 millimeters, but I want to reduce 2 millimeters from my desired incisal edge. Now for me, in terms of incisal reduction, if I go more than 2, if I do 2.5 or 3, that doesn't bother me. I just don't want to under-reduce, because under-reducing makes things much more difficult for the technician in terms of managing ceramic. So the numbers I'm giving you is the minimum number. If you go a hair past it, it's okay. So in this case, what we would do first is we would take a burr, get rid of the old composite. So I got all that old composite veneer off, and now I got this TMS pin sitting there. The good news is I actually was able to unscrew it and then bond composite where it used to be. And so now it's time to actually do the incisal reduction on this tooth. In this case, I'm doing it with like a KS1 or 2 burr. And what I don't want to do is leave that shape to the incisal edge. That's a really difficult shape for a technician to manage. And so we're just going to level it off with whatever the lowest portion of the tooth was. And we end up with somewhere around 2.5 millimeters of incisal reduction, simply because that's where that old composite had gone to. If it was 3 or 3.5, it still wouldn't bother me. I just don't want it less than 2. So once the incisal's done, if I was doing 10 teeth, I would do the incisal reduction on all the incisors and the cuspids first, and I leave the premolars till later. I actually, myself, prefer to prep the anterior teeth first, then prep the premolars on each side. But that just happens to be how I would do it. But I would reduce the incisal edge of the canines and all the incisors as my first step. Now we need to place our depth cuts for the facial surface. This is a old 5/10 of a millimeter depth cutter. On this tooth today, because the color of the tooth is very good, I would be using that depth cutter from Bob Winter that had 3/10, 5/10, and 7/10. There's not a big reason to take a lot more off this tooth because the color is so good on it. In the days that I did this, I used a 5/10 of a millimeter depth cutter in the middle of the tooth and a 3/10 of a millimeter depth cutter in the cervical part of the tooth, so that I managed to make space for porcelain. Now, what am I thinking as I'm picking the depth cutter I want? Because I showed you Bob has 3 different depth cutters. I'm thinking color change and the thickness required by the ceramist. So if I need 3 to 4 shades of color changed, I have to figure out how to get that ceramist 7/10 to 9/10 of a millimeter of ceramic. Now, usually you can build a tooth forward 2 or 3/10 and nobody really notices. That means you can take off 5/10 in the middle, and you've given the ceramist plenty of space to even make a shade change of 2 or 3 shades. But that's what I'm thinking, and I'm thinking I want to try and remain in enamel if possible. I want to leave as much enamel on the tooth as I can to bond to. So what that means is cervically, if I go beyond 3/10, I'll start popping into the dentin. Not a huge deal. If I need to do it, I need to do it, because we still have the enamel all the way around the periphery. But I would prefer to leave as much enamel as possible. So just again to review with you, what was the thickness of cervical enamel? This is a classic study from Ferrari and Petroni. And if you look in the gingival third, it's right around 3 to 4/10 of a millimeter. So a 3/10 depth cutter just is about to take the enamel off in the cervical third. Usually on my veneers, there might be a small window of dentin surrounded by enamel in that cervical third if I do a 3/10 of a millimeter depth cutter. So I'm doing facial reduction based on color change and trying to protect enamel. Then we simply take one of our burrs, one of the tapered burrs in Bob's kit, or a KS0 or KS1, and we wipe away all of our depth cuts and basically also start to place our cervical margin And for my veneer cases, I pretty much prep my gingival margin even with the gingiva, kind of an equigingival margin. We'll talk later about when we do or don't drop margins below subgingival. But at this stage, we've got our incisal reduced, our facial reduced. I would now do this on every tooth. So I don't prep one tooth at a time. I do the same step on each tooth. So if I was doing 6 anterior veneers, incisal reduction on all 6 teeth, depth cuts on the facial, all 6 teeth, remove the facial down to the depth cut, all 6 teeth. Now it's time to do the interproximal. And there's a lot of different things that enter into the interproximal as to do we or don't we go through the interproximal contact. If the teeth are discolored, and that is a significant complaint for the patient, I will virtually always go through the interproximal and have the veneer extend out into the lingual contact area. I've seen too many cases where years ago I stayed too conservative and the patient got a little recession later down the line, and now all of a sudden you can see margins because I didn't extend through the interproximal areas in that cervical. If we have old class 3 composites, I will virtually go through the interproximal 100% of the time. We know from research from Poomans that at 10 years in her study, the single biggest thing that had increased risk of failure for porcelain veneers was when you left your porcelain bonded to a pre-existing composite. So I personally prefer to extend past old composites and wrap over the top of them so that there's no composite visible. In other words, I enclose the old composites with my restoration. So if there's class 3s that go up onto the lingual slightly, my prep's going to go through and right up onto the lingual and past where that composite margin is. And then finally, what are the other things that dictate whether I go through the interproximal or not? Contour. Think about a diastema case. If you want to close diastemas, if you don't extend your prep to the lingual of the contact, your technician basically has this little wing of porcelain that's just jutting out off the tooth. Instead, if we prep through the interproximal and carry our margin to the lingual, they can make a nice gradualized contour out to the interproximal contact. So anytime I'm trying to make significant contour changes, I typically go through the interproximal as well. And this would be an example of what I mean by class 3 composites. In an area like that, if I was prepping that particular tooth, I would have gone past the composite, but also rolled the prep up onto the lingual to cover it. So you wouldn't see the composite at all. It would be completely enclosed. And as I said, Poomans looked at the same group of patients at 5 years and then at 10 years. And at 10 years, the significant marginal changes occurred in the cases where the porcelain was bonded to a pre-existing composite, but still left the composite exposed in the mouth. So that's why I would extend through and over in those cases. Now in this particular central, if you look at it, there's a small diastema between the two centrals. So I did run this prep through the interproximal to the lingual of the contact. Makes it much easier for the technician to now have a nice smooth contour. But on the distal, next to the lateral incisor, there's no discoloration problem. I'm not changing contour at all. There's no old restoration. So I basically have stopped my prep right at the facial aspect of the contact. Now, why not carry it through? You could. Nothing wrong with carrying it through at all. It's just that as you carry through the contact farther to the lingual, you now have to start taking into account, you have to make the prep draw differently, the path of insertion. And as you start to go through all the interproximals, you're going to take a lot more tooth structure away in order to make a path of insertion that works. An easy veneer is a veneer that has a path of insertion from the facial. It's much harder if your prep suddenly has to have a path of insertion from the incisal. So if you wrap through the interproximal and also cover onto the lingual surface, now you have to make the whole veneer draw off the incisal path of insertion, and you're going to have to take a lot more tooth off. So if I can stay conservative like this, I'll usually stay conservative. And there you can see the arrow pointing at that distal area that's sitting out to the facial of the contact. as opposed to the one that we took all the way through the contact area. Okay, the cervical margin. Do we leave it supragingival? Do we go subgingival? The majority of my veneers the margins are right at tissue. Now, some of them aren't. Some of them go subgingival. So typically the beauty of a veneer that's only 0.3 of a millimeter thick is that porcelain is so translucent as it reaches that cervical area. It's just like a contact lens, which was Mark Friedman's kind of concept back in the 80s, what he called the contact lens effect, where when you put a contact lens on top of something with water under it, you can't see it anymore because it's so translucent. That's the way a thin veneer works with porcelain. You put it to place with a translucent cement and you can't see it anymore. It just disappears. So when I have thin veneers and good colored tooth structure, I typically stay equigingival. So very common for me. If the tooth has recession, I stay typically coronal to the cemento-enamel junction. So I'm still on enamel because that root area of recession can typically always be grafted by a surgeon to cover up the receded area. So when do I do below tissue? Color change. If I need to brighten the cervical significantly because it's dark, the margin's going to have to go below tissue. Probably at least 0.5 of a millimeter if it's about a millimeter sulcus. If it's a deeper sulcus, I may consider even doing a little gingivectomy across the anterior to get about a 1 millimeter sulcus so I don't risk recession later on. And then I'll put my margin about a 0.5 millimeter below that sulcus that we did the gingivectomy on. This would be a perfect case. This tooth, I did the gingivectomies leaving a 1 millimeter sulcus. They started with a 3 millimeter sulcus. This tissue is never going to recede. In fact, what this tissue is going to do is grow back, probably a 0.5 to 1 millimeter. So ultimately, this margin will end up subgingivally, even though at the moment it's equigingival, simply because this tissue will rebound following the gingivectomy. When else would I consider subgingival margins? Contour changes, especially interproximal contour changes. You want to close diastemas. You can't do it supragingivally. If you try and close the diastema supragingivally on the interproximal, it just looks like a big overhang. You have to carry the prep subgingivally about a millimeter so that you can get this nice smooth contour that comes out to close the diastema or the open gingival embrasure. So color reasons, I'll go below tissue. Contour reasons, I'll go below tissue. And of course, if we have old restorations or we have caries that go below tissue, then yes, our veneer is going to go below tissue. I typically don't stop my veneers on old class 5 restorations. What I do if I have a class 5 composite is I extend my veneer up past it. Now, if that old class 5 composite is in an area where there was recession, you might consider taking the composite out and letting a surgeon graft tissue there and then doing your ideal veneer prep in an ideal level. And then finally, if you really are up on root surface, the biggest risk with veneers isn't that they're going to fall off. It's that you might get some stain around that cervical margin over time. So if I know my margin is on dentin or on root, not on enamel cervically, I may go subgingivally just so that the staining isn't as visible when it does happen. Because most likely at 3, 5, 10, 15 years, you're going to see a little dark line showing up where that veneer is bonded to that root structure. So we've done our incisal reduction, our facial reduction, our interproximal reduction, our cervical reduction. Last thing we're going to do is the incisal edge. And as I mentioned, my most common thing is you just make it a butt margin, and they work just fine. This tooth happens to be a very thick tooth, so I actually can go up the lingual. But as I go up the lingual, you have to pay a lot of attention to the path of insertion, because as you prep over the lingual, you may change the path of insertion. If you go too far up the lingual surface, you may change it where now the whole tooth has to draw from the incisal. So when I go over the incisal edge, I want to make it so basically the veneer can fit down and simply roll in from the facial. I don't want to force my path of insertion to a new level. And so I'll take a rounded end burr like a KS1 or a KS2, and I will go up the lingual in this. Why? Simply to make it a really nice, easy seat where it goes to one place. It doesn't do anything in terms of changing the clinical outcome of the case. It makes it very, very nice when you seat it that it goes just in one position. And then finally, what I will usually do is I'll polish the entire prep, at least the margins. And you can use fine diamonds, which is what I use now. You can use white stones that are reshaped. You can use carbide burrs. But I'll just make sure all of the margins everywhere are nice and smooth and fresh. And then we'll make our final impression and make our temporary. And this temporary was actually just freehand composite that was done without bonding agent, so I could pop it off, did a little staining on it and polishing, and then spot bonded it to place. So this is this same patient a couple weeks later. She comes back in for seating. You can actually see the gingiva has already rebounded a little bit over the margin on that prep. So that prep that was supragingival or equigingival is actually now slightly subgingival just in 14 days. And there's the final restoration in place. This happens to be a stacked ceramic restoration that I actually did the lab work on years ago. And it's about 3/10 of a millimeter thick in that cervical margin area. It's about 5 to 6/10 of a millimeter thick in the middle. And then it's about 7 to 8/10 up towards the facial incisal. And the incisal edge porcelain itself is probably 2.5 millimeters thick. So those are the steps I follow when I'm doing porcelain veneers. And the reason I like showing this single tooth is it lets you really think about, what do I do step one? Evaluate the tooth for condition, color, old restorations, and then identify your incisal edge position, do your incisal depth cuts, then identify what you need to do for facial porcelain thickness based on color, and then do your facial depth cuts, remove the facial, then look at what you have to do with your interproximals based on, is there old restorations there, is the tooth rotated, are there diastemas, then your gingival margin, then your incisal edge, and then finish the case up. Now, just to show you what that would look like, what would be different if we're doing multiple teeth, I'll show you daughter Julie. And this is Julie about 8 years ago. And Julie decided that she didn't like her anterior teeth. She actually hadn't liked them for a long time. They have kind of a mottled enamel on them. There's little diastemas between most of the anterior teeth. The tooth position isn't awful at all. It's just that they're not the pretty teeth that she wanted. And so we made the decision to do some very, very conservative veneers. Now, they are going to involve some preparation because there's some small diastemas, so I'm going to have to prep through the interproximal in those regions. And I want to give the technician adequate space to get the veneers that we're trying to achieve and have a positive seat. Now, what's different about Julie, as opposed to the single central, is we want to change tooth position. I'm going to lengthen the teeth very slightly, and I'm also going to come facially with the teeth. And so I don't want to do my depth cuts into Julie's teeth. If I do my depth cuts into Julie's teeth, I'm going to be taking more tooth away than I want. The beauty of adding facially and adding incisally is you can take less off of the actual tooth structure. So even though I'm still going to put some finish lines in, parts of these teeth aren't going to get prepped much at all. So how do we know what we're going to do? Well, it's different than the single central. The single central is easy because you're just trying to match the other central. Here, we have to establish our goal of treatment first. What's the outcome we want? So we always start with a diagnostic wax-up. For me, I use drawings on photographs. I send those drawings on photographs to the laboratory with my description, and that leads to the diagnostic wax-up. Once I get the diagnostic wax-up back, I now make a matrix from it, either a putty matrix, which is the easiest, or you can take an alginate impression of the wax-up, pour it in stone, so now you have a stone model of your wax-up, and then make a clear vacuum-formed, or in my case, pressure-formed matrix with copyplast, and that's what I happen to do on Julie. And we're going to now take that copyplast matrix, and we're going to fill it with temporary material and seat it on her teeth to create a mock-up. Now, if she had teeth that were like rotated, sticking out facially, or one was too long, we wanted to shorten it, we would have to actually prep those teeth out of the way before we could completely seat the matrix. The beauty of this is once we get the mock-up in place, we can now adjust it, refine it, make sure she and I both like it, and then all of my depth cuts are done into the mock-up rather than her tooth. So if I want 7/10 of a millimeter across the middle of the veneer for the color I'm trying to achieve, I go through the mock-up. It may only be taking 2/10 of a millimeter off her tooth. That's fine. That's the goal of doing this, is to minimize the reduction on her teeth. So Julie didn't have to have any teeth that I took out of the way first, so we just put our etchant on all the teeth. We load our copyplast matrix. If you want, you can put some bonding agent on the teeth first. I usually don't. I just etch and dry them. Now we let the temporary material cure. This happens to be Pro-Temp Garant. Remove the matrix. Usually putty matrices actually are a little more accurate. They don't have quite as much flash, but you take off the excess flash, and now our diagnostic wax-up is essentially in Julie's face. We can look at the position of the teeth facial lingually. We can look at the incisal edge position. We can look at smile line, all of the things that you would normally want to do so that she and I are both on the same page. This is what we want. And then as long as I know this is what we want, every step we did on that central incisor is the same. It's just now you do it on the mock-up, not on the central incisor. So you do your incisal reduction first across all the anterior teeth. Then you do your facial depth cuts. So I've done the incisal reduction. This happens to be a 7/10 of a millimeter Brasseler depth cutter. I'm doing the facial incisal reduction across there where my depth cuts. I'll go 5/10 up near the middle, 3/10 up in the cervical region. Today I would have used Bob Winter's burr that was 3/10, 5/10, and 7/10. Just ran it right across my mock-up. And then you go ahead and put your final finish lines on, make your decisions about do you go interproximal or not. These are all butt joints because Julie's teeth are quite thin, so I didn't go up the lingual at all. And the gingival margin is put right even with the tissue, which is where I would typically put it. I also did do a little gingivectomy on the right lateral and right central because the tissue was down on them just a little bit. So the steps of prepping, exactly the same steps as that single central incisor. The only difference, it's on 10 teeth. We're changing tooth position. So we do a wax-up, we do the bonded mock-up, we do the mock-up evaluation, then we start the preparation process. And then obviously we use that same matrix to make the temporary, assuming that we liked the mock-up. So here's the temporary on top of her veneer preps. There's the final restorations. These happen to be powder and liquid ceramics. Today, for me, they would most likely be lucite reinforced pressed ceramics like Empress or Authentic, or they could be lithium disilicate ceramics. All three work, so it really depends on your technician and what they're most comfortable with. But powder and liquid, lucite reinforced pressed such as Empress, lithium disilicate, they all could be used very successfully to make these restorations. And there's before and after, and you can see the nice change in the color of the teeth and the surface of the teeth compared to her own enamel, and yet very, very conservative. My guess is these veneers should last 20, 25, who knows how long. I honestly don't, because they're all bonded virtually 100% to enamel, I see very little likelihood of them having problems in the future. And here, just to show you, this is what they look like at 5 years. At 5 years out, the tissue's really stable on that right lateral and central we did the gingivectomy on. And really the veneers are just doing extremely well, as are her opposing teeth. And here's what Julie looked like just a couple years ago. So I hope this section has helped clear up some concepts about veneer tooth preparation for you. In my opinion, in most cases, they do benefit from some preparation. It's better for the technician in terms of controlling finish lines and thickness near the finish line. It's easier for the dentist as far as seating. The goal is obviously to not over-prepare the teeth. And so that's why ideally we try and do mock-ups first. identify our final position of the tooth, and then our depth cuts are done into that, but again, taking off as little as possible to make the room we need to accomplish our final goal. It's been my pleasure sharing this all with you, and I look forward to seeing you again soon.